and we're going to be a little tight on time, but all right, folks, if you are watching on our YouTube feed, you're behind the scenes with our illustrious guests, and we're about to get started here via Zoom. All right, folks, here we go. I'm going to pull up the curtain. Have fun. Thank you. Greetings, everyone. This is Eric Laser, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations across the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on this episode, can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Apologize for the tardiness today. We had some technical difficulties. You do a couple hundred episodes every so often. You run into some things behind the scenes. I think we're all set right now. A couple of quick PSAs for all of you. For all of our listeners to the show, we were just recently doing some analysis and seeing this incredibly good growth of both subscribers and listeners via the webinar. If you do listen to the podcast version of the show regularly or irregularly, and you're listening right now, I'm going to ask you the favor of doing this. Even though our increase in listeners has gone up significantly this year, our ratings and comments on the podcast apps have not. And in order to reach more folks in healthcare and share all these bright spots from all the great guests we have on each and every episode, we need more ratings and more comments. So if you could do us the favor, even as you're listening today, just clicking on Bright Spots in Healthcare on your Apple phone, on your Spotify, on your Android, and just give us a 5-star rating, maybe say a comment or two. That will really help others like you find the show. And if you haven't yet subscribed to the podcast, every live recording we do, like this one today, goes right into the podcast feed within 24 hours. So, and we also do about a quarter of our episodes just recordings. So definitely click subscribe and you get a wealth of information. And there's a library of episodes that you can gain a lot of information and ideas from. So I encourage you to do that. Thank you in advance. Our topic today is localism in healthcare. Today's episode is entitled The Playbook for Local as a Healthcare Strategy. And we have a great roundtable of experts who are going to share with you their insights and bright spots. We're going to bypass formal introductions in the interest of time. But if you want to gain an understanding of the wealth of information you're about to receive, Sherry Kills, our senior producer, is going to post a link to our guest bios for all of you watching live via Zoom. And if you're listening on the podcast, we'll provide that link in the show description. So you can just click on that and read about the experiences and insights of these panelists that you have in front of you today. Today's episode is sponsored by our friends at Rima Health. They're the newest partner to the Bright Spots family. They transform how people navigate the gaps between healthcare and social care. And they combine a personalized, community-based approach to care, making it easier for anyone to access the things they need to make their lives better. They actually combine real people who live in your community with sophisticated engineering and technology to help people overcome some of life's challenges by navigating them to the right community support and healthcare resources. And you'll learn more about them later on in the show, but if you want to check them out right now, they're at remahealth.com. That's REEMA health.com. Okay, excuse me. Got a little bit of a scratchy voice today. I am just about to clear victory over COVID-19, my first bout with it. So it's no joke, by the way. This was a rough one for me, but I'm glad to be here. Just bear with me with the scratchy voice, and I'll use the mute button effectively when I cough. We're going to jump right into it. There's a Q&A module at the bottom of your screen if you're listening live. Feel free to help co-moderate and put questions in there. We will use those questions as appropriate throughout the flow of today's conversation. I want to start off talking large health plans. And talking about how large health plans are incorporating localism, because let's call them national large health plans. How are they incorporating localism into their overall population health strategy? And to do that, we'll bring on our first guest, and that is Cyrus Bathasia. He is the National Vice President of United Health Group. Cyrus, welcome back to the show. How are large health plans incorporating localism into their overall population health strategy?
Hey, thanks, Eric. Thanks for having me back. It's always great to speak with you and be part of this panel. And obviously, your audience is phenomenal. So just a pleasure to take part. So yeah, getting into that question, there's some parts to it. I think, my experience of being in the industry for now, a couple of decades, and being part of, big business, large kind of managed care over the course of now, 13 years. What I've seen is, first kind of early, like we're talking 2010 timeframe, really a lack of understanding by managed care plans about local strategy and, what is the best approach to take. And really, why, what is the why behind it? And from there, kind of moving through a period of acknowledgement that, having deep local understandings and connections are critical to the success of the business. And, I would say that's also, what I'm seeing from just a U.S. health care or a health system trend, is that there was a period of acknowledgement that there was some disconnection there, that the industry had moved away from being local, and that there needed to be some re-engagement with with local kind of localism, as you put it. And from there, really kind of started to see some momentum within the industry and within big business around, how can we do this? So moving more from an acknowledgement to an execution standpoint. And as it is in big business in the US with anything, it became pretty competitive. And so, started to see things surfacing around different studies that were happening across large organizations, looking at different indexes that were starting to be published on, and then starting to see strategy coming together, like social health bridges and different types of strategies where, organizations could measure healthy days, or, different types of kind of innovation centers focusing on community and understanding things like partnerships, both partnerships at the local level, but as well regionally and nationally, seeing things come up like City Block and kind of different other initiatives where there was investment that was starting to happen in those communities. So have seen really over the last 5 years or so, a ton of investment going into things like housing, for example. But, through that kind of initiative, also seeing organizations starting to pop up that understand the desire for large managed care organizations and health systems to become more local. So organizations like, for example, Unitas or Healthify, WellSky, these like community aggregator type systems, as well as, organizations that are localized through community activity or community health worker type models, and building those connections. So through those types of programs, models, technologies, big business is able to start to get more involved and more engaged. So a lot of different activity happening in the space, kind of across the industry. I mentioned a few, but does that help with answering the question from at least my perspective?
That's good. That's a great way to get us going. I'm going to bring you in later on to ask you a couple other questions, and maybe we could target even a few more bright spots that you've looked to. But let's hold off on that. I want to bring in a different perspective. We're fortunate today to have, I'll call sort of slightly non-traditional guest to the show. We have Adrian Fenty. Now, if you don't know who Adrian is, he is the former mayor of the District of Columbia, a small little city, as Washington, D.C., and he's also the managing partner at Mac Venture Capital. And so, Adrian, we don't have to get healthcare in the weeds on healthcare right now. I know you're traveling right now, so hopefully we'll be able to hear you. But as the former mayor of Washington, D.C., you saw Medicaid challenges front and center. What are maybe some of the ideas, thoughts, or suggestions you can offer health plans and providers in the audience around, tackling big challenges at a local level?
Well, first, I want to say thank you. Non-traditional is probably the best compliment I've ever received, both in and out of office. It's usually much harsher than that. So for us, what was really important, and so we were a very unique city. We had no mayor ever is in charge of Medicaid and Medicare and transportation and homelessness like the governor's office usually is. So we had all of these things. So what was really important for us was to figure out a way that agencies could get directly to the people because they were really disconnected, and in every way. So it manifests itself in homelessness and in child welfare and in our hospital systems. So we were very supportive of either something out of government or out of the private sector that would get people out onto the streets and connect with them. And we had a lot of agencies. It was easier for us to do that than a big state because we were a city and a state. So that was really what we focused on. And so we had a really big inefficient hospital. We closed that down for a much smaller, more localized hospital right in the middle of a lower income community. We had homeless residents who were living in shelters or on the streets. We kind of closed down shelters and opened up supportive housing. And all of this we paid for with, federal, Medicaid, sometimes Medicare, and other health service dollars.
Great. I think now we've got a great base. Let's bring in a health plan that works within a health system. And I'm going to bring in Kendra White, and she's the Senior Manager of Medicare Community Relations at UPMC for Life. And so how is the UPMC health plan, Kendra, approaching local as a strategy to their business?
Yes, that's definitely part of it. And I want to thank you again for inviting me back on this forum. I think it's such a great opportunity to tote our programs and what all of these and hear what all these organizations are doing. UPMC Health Plan is basically local. We are the hometown plan, affiliated with the University of Pittsburgh Medical Center. I've actually been with the organization for 20 years. So I've grown up with this plan and I've seen it from its early days. And the one thing that's always reigned true is our commitment to the communities and the people that we serve. So I think, over the last 3 years with the pandemic and seeing how it's changed the way folks approach their healthcare, our teams look to uniquely clear the clutter and get back to focusing on people. So I think our strategies, I have a team that's across the state of Pennsylvania and they live in those areas. So they're committed to those communities. And so I have a team that does outreach for Medicare. So they're focused on wellness, health prevention, promoting access to care and resources, meeting people where they are, going to community centers, whatever groups they can get in front of, senior centers, care facilities, etc. And then the other arm of my team is a SNP, which is a dual eligible Medicare and Medicaid team of community representatives that also work to enroll those folks into our plan, as well as retain the membership that we have by showing up for them, putting together programs, connecting them to resources So it's always been a grassroots effort around the communities in which we serve, but most importantly, where folks live. Particularly in some of these populations, they're not necessarily going to go to an event or an activity that's geared towards their health. Either they don't have time or the resources or transportation. So we always look to unique ways to get those barriers, break down those barriers. I like to say clear the clutter, so to speak, so that it's more about the people. And in the end, we're building trust with those constituents and members, et cetera, in the communities.
Do you is there a mandate or a culture or cultural kind of drivers that have folks being hired sort of in the communities that they're designed to serve in their roles? I mean, I know Pittsburgh, relatively speaking, isn't a huge market, but still being able to hire that way, I can imagine has some inherent challenges. How does that work?
Absolutely, Eric. Over the years, our organization as a whole is so dedicated to diversity and inclusion, and that goes across the board. It's not just how we interact with people, but how we hire people, and always being sensitive to those issues, particularly with language barriers. We always try to ensure that we have access to translators or materials needed in other languages or other assistive devices, etc. But as far as diversity in our employees and the teams that we're putting in the community, I'm very proud to say that my team is just that. It's fitting in with the people that you're serving. I have one rep that I actually was just telling a story this morning about how he would just walk the streets in one neighborhood and just talk to people and get to know them and listen to their stories. And, he was one of our best salespeople, but it's not like your typical sales job where you're trying to sell. You're just building those relationships of trust so that they, when they're thinking about a plan that they know that cares about them, it's going to be UPMC health plan.
So I just want to break that down. Obviously, so hire from the community, number one. Mm-hmm. Two, you obviously have to have a diverse hiring strategy. That goes without saying, but certainly is being emphasized more than ever, I think, in 2022. As far as language, which is always a challenge in this country, right? Because we're on an island here, and a lot of us did not learn a second or third language like our friends in Europe do. So do you try to hire bilingual and then augment with translators? And can you just quickly comment on how you integrate translators into the whole member experience?
We do. When we're having large events, particularly I'll use the COVID-19 vaccination rollout and initiatives that we did. We had a mobile health unit team that went into communities to do vaccines in the communities, and we had translators available with us. So that was one of the most important things. You have the vaccines, you have the people, the manpower, and then you have somebody that, if someone can't speak the language, whether it's Russian or Mandarin or, whatever, not even just Spanish. I mean, that we tend to think, oh, English second language, but there are multiple diverse languages that we're always, if we don't have someone available, we make sure we make a phone call to somebody that can talk to them to communicate.
That's great. I wanted, you brought up DSNP, so I'm going to bring in Justin Lees, the co-founder and CEO of Rima Health. And Justin, can you provide another example of how maybe a national carrier is approaching the DSNP population at a local level? Because those are obviously highly vulnerable, harder to reach.
Yeah, for sure. Yeah, I can tell you, I'll tell you a story about a national plan that we've worked with that's trying to do good local community-based work, even though they're a national plan. So they had about 3,000 members that they knew they needed to get engaged in their programs, like Kendra's talking about here. But they couldn't get them engaged with their own model. Their own model was typically about 24 outreach attempts, a mix of in-person and telephonic, half clinical, half non-clinical. And so they sent these members to us for whom that model didn't work. They couldn't get them engaged. So these 3,000 members had an average 12-month claims cost of about $43,000 per year. They had a behavioral health diagnosis like SUD, OUD, SMI, et cetera. They have at least one chronic condition. And as I mentioned, they weren't being engaged by the health plan. So REMA, takes this on. We engage this population, and we used a number of the strategies that have been discussed here by Kendra and others. So like many of you know, having this local presence and taking a community-based approach is the best way to work with a population like this. So we use what we call a community guide in combination with a 24/7 AI-based messaging engine. Let me just
define a community guide for everyone.
Yeah, great. Yeah, I'll break this down. So community guide. You can think of this like a community health worker, but what we've figured out is that you can't require that certification because requiring it often acts as a barrier to hiring people that would otherwise be a great fit for the role. A lot of our community guides do have, they're degreed and have these certifications, but it's not a requirement. We know it's important to hire from communities we serve. And that's our priority, right? And it's that shared identity and shared experience that act as a helpful head start for trust building and then eventually a relationship. But then the other component, we've learned that you can't stop at simply having a local presence. The second piece of the puzzle is that you have to support that local presence. And so we use a tech platform to solve this problem. You have to be careful not to build a lot of tech that you expect your members to use because they're very unlikely to want to or often even be able to use it. I'll admit I've built plenty of tech in my health tech career that went completely unused by the members it was intended for. So I think it's important to focus on supporting our community guides. So you heard me mention this earlier as a 24/7 AI-based confidant. But basically all the messages we send are sent as text messages. They're sent by our community guides, but our software is making suggestions on what to send. And all of this for us has been informed by our data models that are constantly learning, what's the next best thing to do with a member. And so we use this combo of SMS, phone calls, and in-person visits to do our work as directed by our software. Go ahead, Eric.
I was going to say, you have these unengaged DSNP members now. I just want to make sure, right? And could you give it, how did you just approach implementation or engagement with this large carrier and maybe share with you said, I think it was $43,000 a year. Did you say about 3,500 members? So take us through sort of implementation and maybe results just so we could understand how this is all working.
Sure. Yeah. I mean, as evidence that a combination of a local approach and the right tech works to engage with this population. With this group, we achieved an engagement rate of 84%. We found an unmet social or clinical need with 94% of the engaged population. And then after 12 months of engagement, we had reduced overall claims costs by 40% in our engaged population compared to a control group reduction of 28%. So ultimately, it's an ROI about 4.9 to 1 that we return back to the plan. So I think just, evidence that the local approach, when combined with the right support systems can be really effective.
So let me back up. I just want to make sure I'm clearly understanding all of this. I have a couple of clarifying questions. Hopefully, I think a lot of the audience probably does too. You said 3,500, we'll call them unengaged DSNP members. What was this plan doing as far as you engaged, I think, somewhere over 80% of them? What was there a benchmark or a baseline, I should say, that maybe the year prior, or maybe I don't know if you did a control group where the health plan was trying to engage them without the dual coach technology approach? Like, was there an increase? If you were 81%, what was the carrier prior to you engaging these members at?
Yeah, I don't actually know the specific engagement rate for this population. We typically find a plan doing this work is engaging with this population at a rate of between like 2 and 20%, something like that. We often get this question because, look, 84% is high. And I've spent my entire career working in the space, always trying to eke out a couple more percentage points of engagement. And honestly, this is the first time that I've seen engagement rates like this. And And so, I mean, what I can say is that you have to do a lot of things really well in order to get an engagement number like this. All the things we've heard here, right? You have to be local. You have to hire from the community you serve. You have to support that local staff with the right tech and the best training. We use data models to learn and optimize our outreach, use multiple channels with the right messages. So it's a lot of stuff you have to do right. And namely, I think one thing worth mentioning is SMS, right? We have the benefit of using that as one of our channels. And I think it's important to have two-way SMS. I know many of my health plan friends are currently saying to themselves, well, that's great, but we're not allowed to text our members. This is a topic for a different discussion. But I'll just say quickly that you got to meet members where they are, right? And all of them are texting. And texting is also a health equity issue, and every plan should do the work to make it happen. We've gotten good at working with plans to create a strategy with their compliance team so that we can text. But we actually have a good blog post on this. It's called "How to Text Your Members and Not Get Sued." But I digress. So to answer your question directly, our goal is meaningful engagement. We define that engagement specifically because you have to have some definition for it in this 84% that I'm talking to you about, as 4 inbound text messages, 1 phone call, or 1 in-person visit in a month. We usually have a lot more interaction than that, and I think it's important to have more than that. But this is how that.
So what does that mean? That sounded like the outbound activity from you guys. You're defining, so they have to engage in at least one of those things?
Yeah, it has to be inbound. Yeah, to meet that, to get it, be part of that 84%, it has to be inbound. So they are sending us text messages. We are talking to them on the phone. We're having an in-person interaction.
Okay.
All right. And Eric, I don't know if I can lift the plane up a few thousand feet, but just to make a very simple point is that, what Justin is talking about is extremely innovative, right? Text messaging and boots on the ground. Innovative in healthcare dealing with poor people. But these are technologies that have been around forever. And of course, putting boots on the ground isn't even technology. So, I think sometimes it takes the private sector to come in and do something creative and innovative to provide a better outcome for people in the healthcare system, particularly those at the fringes and the outer edges. And what's going to be great is not only if REMA and other companies like it continue to expand, but as the bigger organizations, particularly governments, adapt these types of strategies, because then we'll get to even more people who are in need.
Amen. Speaking my language. I agree with that. I want to switch gears a bit. I want to bring in Cyrus Bathasia again. I think, Cyrus, you were mentioning, how big companies are going local as well. And I think that, there's that quote, that I like, where any powerful idea is fascinating, but absolutely useless unless we choose to use it. That's from an author, Richard Bach. That wasn't my own. But I wanted you to provide the audience a couple of examples, if you had them, of other organizations outside of yours who you may follow, you've visited, you've worked with, you may benchmark off because they're doing local as a strategy better than most.
Yeah. Well, thanks for that, Eric, and thanks for the opportunity. So two things. So one, I just want to level set. I'm blessed as, first of all, in your last podcast, I'm a first generation immigrant. I came to the U.S. With very little, without even having citizenship or having a green card to stay in the country, and my family, without the ability to work in the country, really experienced a lot of trials and tribulations related to social needs and health. And as part of that, that really fuels my fire. And so where I find myself now and in the organization where I'm at, I've had the opportunity to travel the world looking at best-in-class healthcare models, healthcare delivery, and health system models to try to bring back to the U.S. In some cases within the U.S. To understand aspects of scalability and best practice. And so I think, Eric, that's what you're looking for this audience is what bright spots have I identified inside of the U.S. that I can share here and outside of the U.S. And 2 examples come to mind. First is the South Central Foundation and their NUCA model. They're based in Anchorage, Alaska. And for the folks who aren't aware, just a little background, that Native Alaskans are one of the most have been historically one of the most marginalized populations. Obviously there's several we could talk about, but the history of the Native Alaskans is one in which their healthcare and those individuals had been institutionalized, and it created a significant amount of distrust within that community and the health system. And as such, over time, the health outcomes of that population were poor. And South Central Foundation was an organization that was providing a lot of the basic care to that population, and went through a transformation that was really kind of well thought out, and became what I would call a best practice, where they were able to move from some of the poorest health outcomes to some of the best health outcomes and patient experiences, to the extent of which they're the only two-time Malcolm Baldrige winner, which, for I would imagine many of your audience would know, that's about the highest honor you can get in healthcare in the U.S. And they did it through really kind of a couple of things. One was, they worked with the redevelopment of operational principles, and they use an acronym called relationships, starting with the R, the relationships between customer, owner, family, and provider, and fostering support. And I use that term customer owner, and that's really important to cue in on. They don't think of their patients as patients. They think of them as customer owners. It's a total change in the way that we typically approach, the hierarchy of healthcare, where the patient many times is put at the bottom. They actually put the patient at the top of the relationship, and they call it out through language. The E in relationship is emphasis on wellness of the whole person, family, and community. L is locations, that they're convenient for customer owners with minimal stops to get all their needs addressed. Access, A, optimized and waiting times limited. Together with the customer owner as an active partner. Intentional whole system design to maximize coordination and minimize duplication. The O is on outcome, and the process measures continuously evaluated and improved. They do a fine job at this. They have some of the most sophisticated data analytics that I've seen on understanding experience. N, not complicated, but simple and easy to use. S, services, financially sustainable and viable. H, hub of the system is the family. I, interests of customer owners drive the system to determine what we do and how we do it. P, population-based systems and services. And S, services and systems built on the strengths of Alaskan Native cultures. And the leadership team, I went through their new hire training. One of the things that the leadership team really focused on was sharing their personal story. Similar to what I just did when I started this statement, Eric, they were very open about sharing their personal stories. Each one of the ELT at that new hire training, it was a week-long training that I was part of, took time to come on stage and talk about their experiences and what brought them to the South Central Foundation, and how that connected to their sense of purpose and being. And so, I wanted to call them out as a national best practice. I have an international best practice.
Cyrus, before can I hold you off on that second one? I want to come back to you on that.
Please. Yep.
You gave me a really good segue, so I'm gonna take
Okay, good. Let's do it.
So I was telling everyone earlier on the show, I was going to inform you a little bit more about our friends at Rima Health. And typically at this point in the show, if you've listened to it, I read 3 to 4 lines about Rima and why we decided to partner with them around this kind of content. I'm going to skip that. Cyrus teed me up. I am a big believer just in what that people don't buy what you do, but they actually buy why you do it. So let's take a couple of minutes real quick. I'm gonna bring Justin back on, put him on the spot here. Justin, so you're an entrepreneur, you're very successful. What inspired you to actually start a company focused on supporting local community members?
Yeah, great, Cyrus. I'll follow your lead here. Yeah, tell a little bit of my story. Yeah, it requires me to tell the story of why we founded REMA. It requires me to go way back and get really personal. But I promise I'll fast forward quickly. So I mean, my parents got divorced when I was 2 years old. My dad left. I grew up without a dad. My mom was a single mom with 3 kids, and we were poor. We moved around a lot. It was just a chaotic childhood. We were on a number of government programs like Medicaid and food assistance. And I just feel really lucky to have emerged from my childhood the way that I did. Certainly have a number of advantages, like the fact that my mom was just had good social connections. There were months on end that we would have been homeless, except we could live with my grandparents. And turns out that's helpful for a kid to emerge from the childhood that I had. I could regale you with stories of people that did kind, generous things for me and my family, but I'll tell one quick one. And that is that we had just moved into a new apartment. We lived just outside of Youngstown, Ohio. I think it was about 5 or 6 at this point. And a couple of friends came over to visit, and they saw that there was a bunch of dirty laundry just piled up everywhere. And the next time these friends came to visit, they brought with them a laundry hamper to give us. And they had filled that laundry hamper with a bunch of groceries that they knew we needed. And look, I don't remember what the food was. I don't remember eating any of it. What I remember is clinging to my mom's leg in this kitchen and feeling the happiness just radiate off of her as these friends did this kind, generous thing. And so, yeah, look, this is what REMA does. We try to provide social support like that to people that, unlike my mom, don't have it built into their lives. And those experiences shaped my passion and approach for the work, for sure.
Yeah, love it. So again, remahealth.com. And you guys have an interesting case study that quantifies the impact you can make by combining a human coach with the technology platform that you have. It's a quick read. I read it in preparation for the show today. So if you guys want a copy of that, I could just quickly email that to you personally from my email address. So I'll have Sherry put up a poll, and if you want that set of information, I think it's like a 3-pager. It reads in about 120 seconds, maybe 3 minutes, but it has some interesting stats and information that I think would be valuable for you guys all to take a look at. So optional. Click yes, I'll send it out to you and you'll get all of that. Sarah, stay on hold here. I'm going to come back to you. I want to stay quickly in the US and go into the urban setting and bring back UPM, my friends at UPMC. UPMC, geez, I don't know. I'll play the COVID card there, Kendra, sorry. So can you share with us an example of a local program in an urban setting that maybe you've been implementing, whether it was pre-COVID or it's post-COVID, that you think is an effective way of getting local?
Yeah, I think I've heard every presenter say the word trust. And I think, that's always a huge thing when you're doing any type of community programming is, who are these people? Why are they here? And so I think part of our mission and vision is to go in to these places where people are. We're meeting people where they are. And something that has been successful for us is working with the high rises throughout our service area, but particularly around the Pittsburgh area. There are some senior living facilities that not just low income, but also, where the folks that we serve, they reside. So we have great relationships with the service coordinators in these buildings, and we've done various programming over the years, mostly centered around preventive health. I did see a few questions about just that. Something that UPMC is always a part of our mission is making sure folks get that preventive health, preventive screening. So we do that in these community settings, whether it's in their community center or We bring our 45-foot Winnebago that's bright purple, and it travels around the service area with us, and we can do those screenings right on the unit. And so over the years, we've showed up. It's people that come to expect our representatives in those communities. They know their names. They look at them as a trusted resource for healthcare. And also, if they have questions about particular benefits, whether it's Medicare or SNP or even Medicaid, connecting them with someone that can help them. That's our goal and our mission. And I think, we've heard feedback in the past, my health plan shouldn't be doing this. Why is my health plan worried about my screenings? Well, because it's, we're not just your health plan. Why can't we be your plan for better health? It's giving them resources and education to know that, whatever preventive screenings they need and that are recommended for them are also covered by their health plan. So they won't have to worry about, having those types of financial burdens in addition to taking care of themselves. So, that high rise is just one unique way that we reach people. And that's something that, all my years here, we've always it's just been something that we do. We work through, usually it's a service coordinator or a building manager, or, they used to have more staff, obviously COVID changed that a little bit, but we are getting back to a lot more in-person interactions, which, I think a lot of those folks need and they thrive on. They do really well with being able to have that personal touch and that face-to-face interaction.
Justin, before we go with an international bright spot with Cyrus, how do you see members being affected by these local programs? Could you build upon some of the things that Kendra just shared?
Yeah. Maybe I'll just tell a story of a member that we've worked with. Selfishly, I really like telling. So her name is Donna. I just like telling Donna's story because she has a lot in common with my mom. So she is also the single mom of 3 kids. Her partner also walked out on her. But unlike my mom, Donna graduated out of the foster care system, and so doesn't have the same built-in social supports that my mom had. Donna had just been laid off from her job. She was struggling to put food on the table for her kids. And she was worried about getting evicted from her apartment because she couldn't pay her rent. So when we met her, we just exchanged dozens of text messages about last night's episode of The Bachelor. And that's oftentimes how our conversations start. I think it's important to just have like a non-clinical approach to the work. And it's through that, those conversations about The Bachelor that we eventually unearth that she's struggling to put food on the table for her kids and worried about getting evicted from her apartment. So we help her meet those needs. And it's a mix of in person, so we often go in person, and a lot of texting and conversation along the way, and then eventually, as we meet those needs and build trust, 3 to 4 months into the relationship, we're able to have more of a clinical conversation, and so eventually we helped Donna get an appointment with her PCP that she had not seen in a few years, and fill a prescription that she hadn't filled because she thought she couldn't afford it. So, it's a great human story, but then, for us, there's just a bunch of tech happening in the background as well. Like, we knew that Donna was likely to respond to a text message in the middle of the day about pop culture because our data models were telling us that. Same with, we knew Donna was likely to have a housing need and a food insecurity need. And so then we can direct the conversation that our guides are having in that direction to ask specific questions and unearth this stuff that is typically harder to unearth with more formal assessments.
Wow, that's impressive. A little freaky and super impressive. You're able to do that. That's great. And Cyrus, I want to now bring you back on. I know I've had you in the bullpen here, right? I don't hope I didn't ice you too much. So you were going to mention a bright spot that you experienced or learned about overseas that maybe could be brought over here. Right before you do that, I just want to make sure, because I'm going to ice you just a little bit more. Cyrus had mentioned he's been on the show before. I mentioned earlier, I do about a quarter of the episodes are one-on-ones and they're recorded. According to Sherry and my notes here, The episode with Cyrus dropped on November 11th, 2021. So not that long ago. It's in the podcast feed. If you want to learn more about this gentleman in front of you and some of the wealth of information he has in all this area, I encourage you to listen to that episode, November 11th, 2021. So there's a little plug for you, Cyrus. Go ahead. Let's share that bright spot.
All right. Well, thanks for that, Eric. And so I think it was perfect that Justin, you provided that story. And, I am grateful you provided a little bit about your personal story because there's some interconnection there. So for me, my mom as well was an inspiration to me. And ultimately, it was nursing that when she went into nursing, paved the path for us to find our way to a green card, to equal footing, and ultimately to kind of equality, inclusion within the US. And that paved the path for me to go into nursing as well. And when I entered nursing, I found, as many nurses do, especially nurses that enter into long-term care, a lack of quality in the services being provided. And I was also fortunate enough, as I made my way up the ranks into management, to see that the cost was unsustainable, and was, part of witnessing a lot of folks who just simply couldn't afford to be in those long-term settings. And that's where this international best practice came to play. And I was introduced to them through a board role I have with the University of Minnesota, and a partnership with a group called the Buurtzorg, and they're out of the Netherlands. And it's Dutch, and it translates to community care. And it started in 2006 with a group of 4 nurses in a small town called Almelo, and them also recognizing the challenges with long-term care and the way that elders were being treated, and having a better way, a way that was aligned to their ethics and their craft nursing, and really being able to drive. And when I went to Almelo and spent time with Joost de Blok, their CEO, and the leadership team, and actually went into community, there was actually a lot of connection to Justin, what you described in your model, of really having the client come first. Some of the things that, really kind of struck a chord were a comment about coffee and conversation. So a lot of what they were doing was just building that personal relationship with the patients. They already knew that these folks had a lot of challenge in their life, both medically, socially, in some cases behaviorally, and even safety. And so they would find a way to just sit down and have coffee, which is really a common bond for many folks in Europe, and spend time in their environment, in their homes, learning about that client. And they said, part of their model was really keep it simple, right? So coffee and conversation was something I left with, and keep it simple. And what that meant was the client came first, but also that they recognized the bureaucracy. And this is part of why they haven't yet come to the US, because they actually have scaled this model internationally. It's one of the only internationally scaled healthcare models, that humanity comes over bureaucracy, and that the client comes first, but that they allow their teams to self-manage. So actually nurses from that community managed those teams. They'd have small offices in that community, and they would be able to self-manage. Supporting the independent teams was the idea of the Buurtzorg. They'd provide the back office functions so that they could have what they needed, both the tech and other things. But ultimately, they didn't drive the community process. That was done through the self-managed teams. That model ended up covering the Netherlands, and then scaled across Europe, into Asia, into Australia, South America. When I went there, there was people from all around the world that were actually coming to study the model. So anyway, the bureaucracy in the US was the part that prevented them from yet making their way. But through partnership with the U of M, I was introduced, and we're still talking about that. So I'll stop there, Eric. I hope
That's great. Just so everyone knows who's listening, in the show descriptions on the pod, Sherry will put the links to these two organizations that Cyrus brought up in case you guys want to check them out, along with REMA Health as well. I have a couple of questions left. I know we've got a bunch from the audience, just we're a bit tight on time today. I want to get into SDOH and the intake and maybe what everyone else thinks about an SDOH intake and how some organizations are doing it actually differently. So I want to cover that because we only have 8 minutes left. And then I want to end and talk about big picture strategy and how health plans can learn from startups and tech companies and bring back in Mayor Fenty to close us out. If we have any change after that, I'll take a few of these questions. There's some really good ones in here that I've been dying to ask. We've just been really tight on time. So Justin, how do I want to say it? I mean, how is what you guys do from your collection of SDOH and what you need for your data models, how is that different from maybe what everyone else who's listening to the show right now is familiar with?
Yeah, it's a good question. I mean, I think there's a lot of good work being done in terms of assessing social determinants of health, and there's like the PREPARE assessment, there are lots of good work. And I guess, what we have learned is that so oftentimes a formal assessment like that can kind of act as a wedge between you and the person you're trying to interact with. And so, we are not as focused on measuring population health. We're focused on solving problems for members. And in order to do that, you have to be able to build a relationship. And so we have the benefit of our data models informing some things about the member before we're interacting with them. So if we know someone is likely to have food insecurity, right, we're going to ask them about school lunches for their kids. If we know someone is likely to have housing insecurity, we are likely to ask them about their landlord. As a way to unearth this stuff, these are just examples, but as a way to unearth the social determinant needs that they might have, without having a formal assessment. I'll use my mom as an example again, right? If someone had asked my mom, "Are you struggling to put food on the table for your kids?" she would not have answered honestly because it was embarrassing and she felt a lot of shame about it. And so I think, at least for the work that we've done, we have found it's important to come at that with respect and not really even explicitly asking because it induces this shame response that isn't helpful for anyone.
I love that. So it's a much more subtle way of extracting information and then doing so getting much more accurate and full information and full data and information. Incidentally, if you want to pick Justin's brain on any of this, you don't need to necessarily hire Riemann to learn some of these things from Justin. You've already received an invite to complete a 3-minute feedback form from me. I'll continue sending it to you until you take it. We just use that as a form to make sure we're doing better each and every episode. All of you know that we listen to these feedback form, the feedback you give us to produce programs into the future. In that form, you could request an introduction to Justin, and I will personally do that. I'll send an email and introduce the two of you so you can pick his brain and get some insights into what they're doing differently, because I think they're doing some cool things differently. Adrian, I want to bring you back in. I appreciate it. I know you've been navigating your way to your meeting to Dallas. What can health plans learn from successful tech and healthcare startups around the country about launching or accelerating programs or strategies, whether it be going local or some other initiative? Because I know a lot of the folks in the audience are at bigger organizations and probably don't get the luxury of learning from some of the quick and nimble companies out there.
Yeah, and I sit right in Menlo Park in the heart of Silicon Valley. One of the reasons why venture capitalists like my fund are so excited about companies like REMA is that they're using it's digital health. So REMA is AI, it's text messaging, it's it's using humans in a creative way to go out and get people who otherwise would fall through the cracks. We've invested in kind of oncology software companies that are going to make it easier to have cancer patients get all their information, and we've invested in companies that kind of reach out to minority groups within big Fortune 500 companies And all this is being done through telemedicine, telehealth, digital health. And in a crazy way, the pandemic has just expedited what I think many people in healthcare, government, and startups thought was already going to happen, and make it happen faster. And that's innovation, thinking outside the box, being able to get to people in healthcare who otherwise wouldn't have gotten to in a fast, easy, effective way. And so that's why we're excited, and hopefully these businesses will grow and others will adapt their innovation, and that will make it great for us as investors because the companies will be successful, but it'll also make it great for people who need better healthcare.
Yeah, I agree. Thank you for that. I'm going to ask Kendra and then Justin. I got questions from the audience. If we could try to be quick, we have 3 minutes here. A question for our Kendra. This is a question for Kendra. Could you share some of the unique ways UPMC has found successful in breaking down barriers to reach people? I don't know if your hiring process is one of those, but in case it isn't, anything else to elaborate on there?
It just, I know we only have a few minutes, but I think the hiring of the people that are showing up in these areas and, just really listening and being a part of that culture and that community really goes a long way in building trust with people. And, Justin's theme about his mom, how would you want to be treated? How would you want your family to be treated? That goes a long way too into everything that my team does on a daily basis.
Great. Debbie asks, Justin, does REMA only attempt to text to initially engage members, or will they go to their home if not responding to texting or a phone call?
Yeah, this is a great question. We would not have an 84% engagement rate if we were only texting, or if we were only going in person, or if we were only making a phone call. I talked about this a little bit, but definitely the ingredients to a successful engagement rate you have to use all the channels at your disposal. So yeah, for us, it means we will send text messages, we will make phone calls, and we will go in person. And what's important is for the right person, using the right channel, doing it in the right sequence at the right time with the right messages. And so for us, we're always trying to hone that and get that right. And that's why we get the engagement rates we do, for sure.
Great stuff. Jess Holmes, I really wanted to ask your question because it's one of the best questions I've received. I just couldn't find time to fit it in. I'm going to have to steal it for my next show, but I will. I just want to thank everyone who took the time to listen today. I say this every episode. We know it's a privilege to get an hour of your time each and every week. So thank you for taking the time to be with us. Hopefully, we earned the privilege of getting a future hour with you. We have a great live episode coming up in 2 weeks that you'll hear about around risk adjustment, which we're excited and have a great panel already set up for you. So thank you all for taking the time. To our esteemed group of roundtable experts, thank you for all the time you took, especially last minute. With me being sick, it was sort of produced within 36 hours. So I appreciate you guys all being so flexible and working so well together. So thank you for that. You just hang on for a minute when I say goodbye to everyone. But this will mark the end of the show. And just remind everyone, we do this for all of you. And I like saying each and every episode, this is your Bright Spots in Healthcare podcast. Take care, everyone.